as the director of the Behavioral Health and Developmental Disabilities Administration. She's now a senior fellow for behavioral health at the Michigan Health Endowment Fund. She's going to kick us off today, and she's going to do wrap up at the end discussion with our panel. We will take brief questions between each presentation, but if you still have questions at the end, we hope to have time then. So I will turn it over to Linda.
Thank you, Kathy, and thank you, Arnold. And on behalf of the Michigan Health Endowment Fund, thank you all for making time in your tremendously busy schedule and with your very full plates to attend this session. It says a lot about your commitment to the importance of this topic. So Arnold, if we could pull up the slides. I have 3 slides. My job today is quite easy. It's to remind you of and ground us all in the realities, the challenging, perplexing realities of access to behavioral health services for Michiganders. Prior to my time at the Health Endowment Fund, the Health Endowment Fund engaged in a study, behavioral health access study, sometimes known as the LTF study, sometimes known as the Health Endowment Fund study. We presented on this study a year ago, but I'm providing 3 slides here to remind you of the sobering realities within that study. Almost 4 of 10 people in Michigan who have a claim that diagnoses them with any type of mental illness, a service claim, almost 4 of 10 of those people did not receive ongoing treatment for their mental illness. So they showed up somewhere, hospital, doctor's office, somewhere, got a claim for any mental illness, did not have treatment. And that is not just our public system. That includes Medicaid claims, Medicare, and private insurance. Similarly, and even more sobering, only 2 of 10 people in Michigan who had claims showing they had a substance use disorder diagnosis, only 2 of 10 received and are getting treatment. Very sobering statistics. If you want more details about how this all plays out in terms of insurance type, I've provided links at the bottom of this page to some nice 1-pagers and the full report. Next slide, please. The next 2 slides just show some breakouts. This first one for any mental illness, this is for all insurance types, breaks it out by their reported gender on the claim. The final slide does the same thing for substance use disorder, breaks it out by gender and by age. So to conclude my foundational remarks, everyone agrees we are not satisfied with the number of Michiganders who are getting the right care at the right time, as Kathy and Arnold introduced, is our purpose. Today, we're really, really fortunate, in my opinion, to introduce you to or reintroduce you to 3 of the greatest resources for you in Michigan and nationally to help ground us in the perplexing challenges related to the bipartisan agreement that we need to do better with right care at right time. And also what's happening nationally in terms of trends. Today, we hope you leave with a better appreciation of the challenge at hand and also of some of the richness of what we have in Michigan in terms of people and resources, but not shying away from the perplexing problems that you all are dealing with now and will consider even more in the next several years in your work. So with that, I would like to turn it over to our first speaker, Kevin Fisher, who is the executive director of NAMI, who will give us the state perspective. And I do want to just mention that in the middle, we're going to hear from, so the flow of this panel is I'm grounding you in statistics, then Kevin's going to give us the state perspective with NAMI, then Melchiah Newman, who is a person with a personal story. Nothing shows the richness and the fracture points in our system better than personal stories. So Melchiah Newman is going to share her personal story, and then Dr. Deborah Peinels is going to share some of the state work that's happening and how it fits within some national work that's happening, as she's a national expert too as well. So I think I've done everything on my list. I'm going to turn it over to you, Kevin. Thank you.
Good morning. Thank you, Linda. And I'm going to get started, Arnold, right into my presentation. And first of all, I'd like to thank everybody for your presence and participation today and for my opportunity to present. So for those of you who are not familiar, NAMI is the National Alliance on Mental Illness. We are the nation's largest grassroots mental health organization that's just simply purely dedicated to building better lives for the millions of Americans affected by mental illness. What started in 1979 as a group of moms gathered around a table in Minnesota who didn't feel that their loved ones had enough access to behavioral health care has blossomed into now, again, the largest behavioral health grassroots organization in the country. And we still affectionately refer to them as the NAMI mommies. NAMI focuses in 4 areas. If we can go to the next slide. We focus in leadership. Well, we listen. NAMI offers and provides a 24/7, 365 helpline at our national office in Virginia, where we take hundreds of thousands of calls each year to help direct people to mental health resources. You may know, or maybe some of us are not aware, most people are unfamiliar with our public behavioral health system. Most people don't even know a CMH system exists until they have a need for that system. So our public, both in the state of Michigan and nationally, I will respectfully say, is really ignorant to our behavioral health care system. We educate. NAMI offers education and support programs in the communities we serve. There are NAMI affiliates in 16 counties in the state of Michigan, and we hope to have representation in all counties. But all of our education, support, and advocacy work is provided at no cost to participants. We advocate. We advocate on the state and national level, of course, fighting for increased resources for persons who are affected by mental illness. And then we lead. We lead through public events like our annual state conference, annual NAMI Walks events, and many others. We can go to the next one. Some of the advocacy issues that we're focused on and have been ongoing here in the state of Michigan are the redesigning of the public behavioral health system, statewide implementations of crisis intervention teams. And if you're not familiar with that, please become familiar with it, because it really speaks to the relationship with law enforcement, partnering with public behavioral health providers so we can decrease the instances of violence and harm to officers and to the public who are experiencing behavioral health crisis. Enforcement of the National Mental Health Parity Act. 1996, the federal government passed the Mental Health Parity Act that says insurance providers need to provide the same level of coverage for behavioral health treatment as we do for all other physical health. The problem is the federal government left it to the states for enforcement, and many states don't enforce it, and we can do a much better job here in Michigan. Expansion of use of mental health courts. Michigan has some really successful mental health courts, whether they are adult mental health courts, juvenile mental health courts, veterans courts. They have produced some really significant outcomes because we don't want to criminalize people because of their mental health disorders. Expansions of Kevin's Law, or Michigan's versions of assisted outpatient treatment. If you're not familiar with that, we should be familiar with it, and we should make sure that it's available in every county, because this is an opportunity for us to get in front of and not be reactive to behavioral health crisis. First episode, psychosis programs. There is irrefutable data out there that says that if we are able to diagnose and provide treatment for young people at the first signs of psychosis, their outcome and prognosis improve tremendously, but we're not taking enough advantage of those programs. And then lastly, everything we do at NAMI leans toward suicide prevention. All we're trying to do is improve the quality of and save lives. Arnold, we can go to the next. So why are we talking about mental illness? We all know this. 1 in 5 Americans, some people even say 1 in 4, is affected by mental illness in a given year. That is a minimum of 60 million people. Yet we don't talk enough about mental illness and behavioral health care in this country, which is again why I respectfully say our society is so ignorant to it. We can go on. Next slide, please. One of the myths, and you'll hear me get into this issue of stigma a lot. One of the myths about mental illness is that it's brought on by a weakness of character. Nothing could be further from the truth. Professionals on this call are very well aware of that, but many people in our society are not. We don't generally understand that mental illness is a product of biological, psychological, and social factors. Mental illness is a medical diagnosis, and until we recognize it as such, people simply won't seek the help that they need. Next slide, please. I mentioned stigma, and I will mention it over and over again because I personally believe, and NAMI's national mantra is, stigma is the leading barrier that prevents people from receiving early diagnosis and treatment that leads to better outcomes. Is as simple as, again, with any other medical diagnosis, you have a far better prognosis if we diagnose cancer at stage 1 instead of stage 4. Same thing applies to mental health diagnosis. Next slide, please. You know, as an advocate, we spend a lot of time fighting for and needing increased funding, more psychiatric beds, more behavioral health professionals. All of these things are really important and needed. So I don't want to give the impression that they're not, but I will restate what I said a couple of moments ago. If we don't change the way we view mental illness in this country, if we don't eliminate the stigma, we can throw all the money at it we want to, people simply won't seek the help that they need. So to me, stigma has to be first. Next slide, please. We know that 50% of all lifetime cases of mental illness onsets by the age of 14, 75% by the age of 24. Again, the reason why we have to deal with this early, we have to help our young people understand that, and I know it sounds cliche now, it's okay not to be okay. It's okay to raise your hand and say, I'm not quite feeling myself. And one of the interesting things that I've learned in the 7 years that I've been with NAMI is this. Us parents, I'll say that nicely, us parents, our generation, are more the perpetuators of the stigma than our young people. As I go into junior and senior high schools and visit college campuses, I've learned that young people are much more open to talking about their behavioral health needs. They're much more open to talk about treatment. They're much more open to talking about their experiences with suicidal ideology. It is us parents who perpetuate the myth that what happens in my house stays in our house. We don't want our coworkers, the people we sit next to at church, and our friends and family to know that we or one of our loved ones is affected by mental illness. We're making it worse. We have to do better. Next slide, please. 16.5% of our youth experienced a mental health disorder in 2018. 59% of students said they were harassed or bullied online. 74% of young people said they identify as being so stressed that they're unable to cope and carry out their daily responsibilities. And this one really hits home. 17% of high school students have considered suicide, seriously considered suicide in the last year. We have to get out in front of this. Next slide, please. We know that, and I said earlier, we don't want to criminalize mental illness in this country. However, we know in the state of Michigan, the largest behavioral health treatment facility is the Wayne County Jail. That makes no sense. The criminal justice system, not only, and I mean this respectfully because I work with a lot of folks in law enforcement and the people who provide care to people who are incarcerated. But let's be honest, no one's receiving the best behavioral health treatment when they're incarcerated. 70% of our youth in the juvenile justice system have at least one mental health disorder. 20% has a serious mental health disorder. 21% of the population in our local jails are filled with people with serious mental health conditions. And I work on the Wayne County Jail Task Force. I think we just issued a report that said we spent over $30 million in the last 2 years providing treatment or quite frankly, housing people who have mental illnesses. It just doesn't make any sense. Linda Zeller mentioned early in her presentation that only about 4 out of 10 receive behavioral health treatment. That's consistent nationally. Only about 43% of adults who have a mental health disorder will receive treatment in the last year. Next slide, please. Only 60% of US counties have a practicing psychiatrist. And we know in Michigan, we have some huge gaps and our friends in the UP are suffering the most. It has actually grown. It was, I think previous statistics I saw said on average, it took 8 to 10 years. There was an 8 to 10 year delay between onset of mental health diagnosis and treatment. Now it's 11 years. And we know now that 90% of people who die by suicide has shown some symptom of mental illness prior to their death. Next slide, please. I mentioned earlier that only about 43% of adults who have a mental illness will get treatment in a given year. If you're a member of a minority class, Hispanic or African American, you could pretty much cut that number in half. And that is because of a lot of issues that I'll get into on the next slide. The one here that I want to focus on also is that we need corporate America to get on board addressing mental health concerns, because America loses $193 billion in lost earnings each year to mental health disorders. And that's a huge effect on our economy. Next slide, please. I mentioned if you're a member of a minority community, you're far less likely to receive behavioral health treatment. And there are a number of reasons why: less access to treatment, poor quality of care, culturally insensitive health care. Right now, where we are in the United States, there's a lot of conversation about this. And there's debate by some who are frankly in denial that cultural competency is an issue. It is. It may not be for everyone, and it may not be in every situation, but it is an issue, and it's one that we have to be honest about and address. Next slide, please. Suicide is the second leading cause of death for young people in the United States between the ages of 10 and 34. It is the 10th leading cause of death overall in the United States. We have to address the issue of mental health care. And the fact is proactive mental health care is suicide prevention. You can't separate the two. We can go to the next slide, please, and the one after. Interestingly, in the United States, in 2018, almost 49,000 people died by suicide in the United States. That's 2.5 times the number of people who died by homicide. Yet, every day when you turn on the evening news, what's the first thing you hear about? It's homicides. We don't talk proactively about behavioral health care, which is suicide prevention. Next slide, please. With all of those bad things that are going on, now we throw a little gasoline on the fire with COVID-19. And we know that it has significantly impacted population across the spectrum. Our young people are suffering because of social distancing. Our seniors are suffering because of social distancing. And there's a link on the bottom of the slide that will address that for more information put out by NAMI. Next slide, please. Another can of gasoline for the fire. Racism has finally been recognized as a public health crisis. We need to have this conversation. We're at a time and space in the United States where I am grateful that most Americans are open to having this conversation. But again, we cannot continue to discount the effect that racism has on our, as a public health crisis in America. Next slide, please. You know, it's interesting. We spend 6 times as much money on breast cancer research as we do on behavioral health research. And not to minimize it, because I have a sister who had diagnosed with breast cancer. But again, it just talks to the stigma and the disparity between how we look at mental health issues in this country. Next slide, please. With all that being said, people overcome the challenges of mental illness every single day. Early diagnosis and treatment leads to better outcomes. And so our message needs to be that we need to focus on behavioral health care. And final slide is just resources. So thank you for the opportunity. Thank you for your presence and participation. And I look forward to questions at the end.
Thank you, Kevin. I will take one question. We can take 1 minute. So before the pandemic, telehealth was heavily utilized in the behavioral health world very successfully. Since the pandemic, that has significantly increased, particularly around behavioral health services. Has that helped the disparity issue, or has it further widened the gap? Can you answer that?
From what I've seen, and is limited information, but is a great question, it has increased. A number of the providers that I work with have spoken very highly to our pleasant surprise that actually teletherapy and telehealth has actually increased compliance with treatment, increased people keeping their appointments. And so I think there's been a benefit.
Great. Okay, and we will take questions for Kevin again at the end. We'll try to hold some time at the end. So I'm happy to introduce our next presenter. Malkia Newman is one of the co-founders of and a teen supervisor at CNS Healthcare's Anti-Stigma program. She is here to not only talk about her work, her professional work in the anti-stigma program, but also her personal story. So I will turn it over to Malkia.
Thank you, Kathleen. And thank you all for attending this session today. I'm very, very excited to be sharing my recovery story with you and fielding any questions that you may have a little later on. I'm ready for the slides, please. And we can go to the next slide. I am not my diagnosis. That's the name of my presentation. And this is me at 18 months old. And the reason why I show this slide is because my mom told me when she was taking me to the photographer, she didn't know if he'd be able to make me smile. Because at 18 months old, I had never smiled. And this is the first smile I had ever smiled in my life. Now, looking back, if they would have had behavioral health, infant mental health like they do now, I would have been a candidate for that because I believe I was born with anxiety. I spent a lot of my years in dread, and we can go to the next slide. But it just helps me to understand more about the struggles that I had. But don't define me by my diagnosis. Next slide. I'm going to share with you my recovery story. I don't know when it started, really. It was an uneasy feeling. Something's wrong. Wrong with my thinking, wrong with me, and wrong with my life. Nobody knows the trouble I've seen Nobody knows. Sadness. It was a constant companion from my late teens on. Disappointments grew like sand shifting through an hourglass. Pregnant out of wedlock and broken family relationships, and I was told it was all my fault. First marriage at 17, first divorce at 19. It was my baby, my Tracy. She's the only thing that kept me from taking my own life. I went to college. I had a 3.86 GPA, dropped out, and never went back. When would I ever see the rainbow after the rain? That's when my quest began. But who could I tell? Who could I trust? Do you see what I see? Do you know what I know? Then came 12-step programs, individual group therapy, even guided prayer. I'd make a little progress, one step forward, 10 steps back, until a friend told me about a little clinic in Pontiac, and Zoloff saved the day. I can see clearly now, the rain is gone. I believe I can fly. Woo! Bipolar disorder. Out of all the mental health treatments, it's one of the easiest ones to treat. And those little blue pills, they made all the difference in the world until I lost a job with benefits, which meant I could no longer see a doctor or get my medication. I went back to that first clinic and they no longer service people with brain disorders, and they didn't even tell me where else I could go. So on the verge of yet another breakdown, a friend referred me to CNS. I got new meds and a new place to stay. So by that following May, whew, I feel good. I knew that I would. I felt so good. I stopped taking my medication and back in the toilet I went again. But I thank God for caring professionals that were in my life at CNS, the doctors, nurses, peers, family, and friends that encouraged me. So now I'm back on meds and back on track. And oh, by the way, would you like to work for CNS? So as you can see, having a mental health diagnosis is really not the end of the world. For me, it was only the beginning. And I have to say, that was then, and this is now. A whole lot has happened in my life. I just want to bring you up to speed. My life is very amazing. 15 years on the job at CNS. The last 4 as the team supervisor of the anti-stigma team. We go all over the nation. I've been as far away as Nova Scotia, Canada, and my team presented at an international conference in Hawaii this year. So when I say my life is amazing, it really is amazing. I've appeared on TV. I've had my face on buses. I've done podcasts. I've opened state and national conferences. The biggest one was in 2013 when I was on the stage of Caesar's Palace in Las Vegas, sharing my recovery story, the one that you just heard, with 4,000 people live and live stream all over the world. The main reason why I was so excited about doing this presentation for you all today is because I consider myself a poster child for community mental health. We all agree that there's things that need to be done, improvements that need to be made, but we don't celebrate the successes enough. I am living proof that treatment works. I am living proof that the work that's being done in community mental health is turning lives around. I was 48 when I was diagnosed. My whole adult life was affected by an illness I didn't know I had and didn't know how to treat. But in the last, it's going on 20 years, in 2021, it'll be 20 years since I got my diagnosis, and my life has never been the same. So please don't define me by my diagnosis. Next slide. And as the team captain or the team supervisor for the anti-stigma team, stigma is in our name, and that's a very good reason why. Kevin already shared with you that many people do not come forward for treatment because of stigma, because of how people are viewed and how people are treated. And I've looked for many definitions of the word. Not any of them really satisfied me, but this was one of the best ones I'd seen. So I want to share with you today. Stigma is the perception that a certain attribute makes a person unacceptably different from others, leading to prejudice and discrimination against them. So if you're a person with a mental health condition or substance use disorder, and people have stigmatizing ideas about you, they consider you less than. And it's very, very important to me to have this conversation with you all today, being legislators, because you are writing laws and passing laws that directly affect people's lives like myself. Next slide. So when you talk about stigma, you also have to talk about intersectionality. And what that means is you add another layer of stigma for any other condition that a person has in addition to mental illness or substance use. Ethnicity, religion, culture, disability, all those things have their own stigmas. And you layer those one on top of the other. And going back to the definition that I gave, it makes you unacceptably different in the eyes of other people. What kind of legislation do you champion and pass if you're viewing the people you're targeting the legislation towards through the eyes of stigma? I have to say that when they passed the law or passed the procedure that people who were receiving bridge cards had to undergo drug testing. They spent millions of dollars on that program, not one positive. So was that based on the facts? Was that based on the data that the Department of Health and Human Services clearly has? No, it was based on stigma. And I have to say the same thing for work requirements. What was that based on? Was that based on the facts? Again, the Department of Health and Human Services has the data that will show most of the people receiving Social Security or other supports have disabilities or have challenges that prevent them from working. And on top of that, the unemployment rate for people with disabilities is 60% higher than everyone else. So when you're making your decisions, what lenses are you looking through? What is driving that decision that you're making? I want to go to my next slide. This is a brief video. I hope everyone is able to hear it from Brene Brown, talking about the difference between empathy and sympathy. No sound. We're not getting any sound. If we can't get the sound, I really want everybody, this is on YouTube, look it up on YouTube, Empathy versus Sympathy by Dr. Brene Brown. And the reason why I wanted to close with this is because when you are looking at another person that's going through situations and circumstances in life, if you're not able to put yourself, your emotions, share what's going on with another individual, then it's easy for you to be disconnected from people who suffer. It's so important, especially these days, because just like they said, and we can go to the next slide since it's not working. We don't have the
Let me try it again. I was muted, so let's try it
Okay.
again, okay?
Thank the Lord. Thank you, Arnold.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection.
Uh-oh.
What happened? Hang on. My apologies.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Sympathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here and you're not alone. Sympathy is, woo, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I had it, yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. At least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
What makes something better is connection. So when you're making your decisions, I just want to encourage you to try to connect with the people, see people and not just numbers, and make that connection, because we're all in this together. People are feeling it more now than ever before. You can go to the next slide because I'm almost done. People who never understood people like me with the mental health condition are understanding it so much better now, being socially isolated, having the shelter in place, feeling that isolation and that loneliness. So now we can have honest conversations where people will start to understand better what it's like to struggle with anxiety and depression. So I just thank you again so much for your kind attention, and I'll be available for questions at the end. Thank you.
Melchiah, thank you. I know you have not been paying attention to the chat while you were presenting, but you should go and check it in a minute, because there are many people lauding you for your great testimony today, your very inspirational testimony. And there was one question, we'll take one question before we move on to our final presenter.
Okay.
And that's, it was a question about your daughter and what resources are available for family members who live with the person diagnosed with mental illness. Are there support groups for family members at different ages?
Yes, there is. I don't think Kevin brought it up, but NAMI is one of the first organizations that I recommend for support for family members. There's also the Depression and Bipolar Support Alliance. They provide support to people with mental health conditions as well as the family members. Unfortunately, on the substance use side, they do have AA and NA that help the people, but a lot of times the family members, even with the groups, don't always get the support that they need. Briefly, I do want to say that my daughter turned out to be an exceptional young woman. She's going to be 50 years old next year. I am so grateful that she made it through this journey. In fact, we're talking about writing a book about our experiences, me, a mom, her, a daughter living with a mom with mental illness. She wasn't impacted by it, but my granddaughter, who's 25, does have ADHD. So when the symptoms start showing up in her, I was able to talk my daughter through what she needed to do. And I talked to my granddaughter regularly about medications and those kind of things. So the book might be expanded to a 3-generation book because of that. But there is life after diagnosis. I feel like I broke the curse in my family. And you'll see it, I believe it's in the bio that I sent, but mental health conditions have been a long-standing issue in my family for many generations. My great-great-grandfather died in a mental institution. We didn't find that out until late in life. All of my mother's siblings, she had 8 brothers and sisters. It was 8 of them total, and every last one of them had at least one child with either substance use or mental health condition. So family information and family support is vital, and that is an area that is lacking. We need to do more to support the families because it's a family illness. It doesn't just affect the person with the disease, it affects the whole family. And thank you for that question. And thank you for your kind comments. I'm gonna go and look at the chat.
And thank you for sharing your beautiful singing voice with us in addition to your very inspirational testimony. So I'd like to present now our last, or introduce now our last presenter, Dr. Deborah Peinels. She is the medical director of the Behavioral Health and Forensic Programs for the Michigan Department of Health and Human Services. She's also the director of the program in psychiatry, law, and ethics, and a clinical professor of psychiatry at the University of Michigan's Medical School and clinical adjunct professor at the University of Michigan Law School. So Dr. Peinels, we'll turn it to you now.
Great, thank you. Well, what an honor to follow Kevin and Malkaya. I will promise you I will not sing. I think that wouldn't be a great experience for anyone. If I could have the slides up, Arnold, that would be terrific. So what I'm going to do is, first of all, just say I do wear multiple hats. And for this presentation, I'm really going to give you my perspectives, not the perspectives of the state or any kind of entities that I consult to, because I do consult nationally and have the opportunity to get the landscape of the national perspective. We can go to the next slide. And I want to start by just talking to you as legislators so that you see where Michigan stands in terms of looking at the national perspective. And then we're going to look at some recent trends in strategies to try and overcome some of the challenges that you've heard about already. And I think it's really great to be juxtaposed with Kevin and Malkaya to see, what the impact on an individual's life can be with these quote unquote systems challenges. So we can go to the next slide. So of course we have COVID-19 as this umbrella situation for us all. And certainly it's taking its emotional and physical toll on the lives of so many. We don't yet fully know what that's going to mean in terms of the mental health of America, but we certainly know by studies that are being done recently that many, many people, and this goes well beyond the public behavioral health system, are impacted by all that's going on, with 40% of Americans at the end of June reporting struggles with mental health issues substance use issues, and even some 11% reporting suicidal ideation. And that's of the adult population. You heard Kevin talk about the concerns around the younger population. We also know that there's healthcare disparities and inequities, and there's access to care, which today's forum is really supposed to be focusing on. We've had challenges nationally across every state with emergency department boarding, time to get into outpatient services, this concept of network adequacy, making sure that we have enough providers to take care of the needs of many, homelessness, criminal and juvenile justice involvement, the suicide crisis, and of course the opioid and related epidemics that are now being labeled beyond just opioids as we look at methamphetamine and other challenges. Next slide. Part of the national challenge is to knit together what is often a siloed system of care. So for an individual who's having a recovery journey or an episode of mental illness or a substance use challenge, they may find themselves in one system that's not interconnected with the others. And so as a goal, as a national goal, everybody's trying to look at how to integrate care and information across these siloed entities. Next slide. We know that there's an overrepresentation of individuals with serious mental illness in the justice system. If you look at the national trends, 4% of the population overall might be labeled as having a serious mental illness. But if you look within jails, almost 20% of the population does. And of those, 3/4 will have a co-occurring substance use disorder. Next slide. Taken from another angle, looking at substance use disorders, some studies have shown that 80% of arrests are involved with people who test positive on some drug screen. And so we know that there's a high proportion of individuals within jails and prisons who have substance use disorders, and many of those will have a co-occurring serious mental illness. Next slide. Drug overdose mortality is a major issue. Right before COVID, we were seeing some positive trends, just starting to bend the curve on some of the overdose rates related to prescription opioids. In 2018, though, 25 to 26% of people who met criteria for substance use disorder access treatment, which meant that almost 75% did not. And as the opioid overdose trends were improving for prescription overdoses, we were also seeing some scary statistics about synthetic opioids, as well as psychostimulants that were like methamphetamine that was on the rise, that created some additional opportunities with federal dollars, but nonetheless some important ongoing needs to address this. And certainly COVID-19, we are concerned is making some of the situation, some of those positive gains we had perhaps not as positive, and we'll see more as we go. Next slide. We know that the justice involved population or the criminal legal involved population is particularly at risk, with data that came out in 2018, looking, for example, at North Carolina, showing opioid overdose rates for former prison inmates was 40 times higher at 2 weeks post-release and 11 times higher at 1 year post-release compared to the general population. And this was just in one study, but other states have replicated that. And we're working really hard in Michigan to bend those trends with intentional approaches to looking at the reentry population. Next slide. We also know that there's a multi-generational effect of these issues. And I think Malkaya said it herself as she looked at her own family. And there's many, many reasons for this. And we're learning a lot more about what we can do to help prevent some of the negative outcomes from very early ages. And one of them is by looking at child welfare, understanding that right now the prevalence of parental alcohol and other drug use is a contributing factor for removal. And so there's a lot of work trying to be done to not just remove children, but to foster better access to care for family systems so that children can stay within their families, but in a safer way. Next slide. We also know there's evolving trends in forensic systems. Next slide. And that includes the individuals that are in state hospitals that were at one time nationally designed to be civil and forensic are seeing more and more of the civil hospitals have forensic populations in them, and that largely means people incompetent to stand trial or not guilty by reason of insanity. And this is data, national data that we see looking at one-day census rates. Michigan is no different. All of our state psychiatric hospitals have a significant percentage of forensic patients in them beyond just the Center for Forensic Psychiatry. Next slide. Across the country, we also see that people are waiting in jails to access state psychiatric hospitals. And many states are trying to work on strategies to keep people both out of jails and out of state hospital if they don't need to, if we can look at that forensic population. And in particular, there's been a lot going on nationally related to the competence to stand trial population. I'll talk a little bit more about that. Next slide. Again, the COVID-19 issues have to be mentioned. The death rates, this is already old data. You hear it every day, the death toll. The acute stage of the virus, and even depression and anxiety for people that will demand the need for ongoing and increased access to mental health services. Next slide. Not to mention the people dealing with grief and loss and what that will mean. So what are some strategies that have been laid out that I think Michigan is really well poised to address and is already addressing? But again, I want to stick with what's happening kind of on a national perspective, just to educate you and give you some information. These slides will be available. There's a lot out there in the public domain for you to educate yourself around things that you might be interested in terms of legislative solutions. Next slide. So the first thing I want to talk about, and I thank Linda Zeller for this because she got me started in this whole work that I've been doing with the National Association of State Mental Health Program Directors. Those are the behavioral health leaders around the country. And in 2017, I was asked to co-author a paper that became known as the Beyond Beds paper, in which we established some recommendations through the work of a national work group on looking at the vital role of a full continuum of psychiatric care. And part of the reason we use this terminology, Beyond Beds, is because for a long time, the media and legislators looked to the state hospitals as the single solution to the complexity of the mental health needs in society. And what we're learning more and more about is that no system can really define its bed need without really understanding its entire continuum of care and what it means to access that continuum. And so building out that continuum is really the strategy that's going to require understanding the terminology that we use. What does a bed even mean? And the paper goes into detail. And again, this is a publicly accessible paper. What does a bed mean? What does it look like to move people out of the criminal and juvenile justice system? Where would they go? How do we get to emergency treatment? What types of beds, again, do we need so that we make sure we have enough, both in the acute system and in the state system? How do we examine data? How do we look at those linkages across siloed systems? What is our use of technology to maximize access and information sharing? And what do we need to develop within the workforce? For example, Michigan's one of the stars in that regard. When we look at our workforce of people who were able to give treatments, board certified behavioral analysts to treat autism spectrum, we were in the lowest number of professionals when I first came to Michigan about 5 years ago. Now we're in the top 10. We've built a workforce of ABA professionals. And also, what are the partnerships, including non-traditional partnerships, not just looking at the state partnerships within state agencies, but looking across, looking at faith-based organizations, community mental health, other community representatives as stakeholders who really want to drive these solutions in a more holistic way, NAMI being one of them and other entities. Next slide. We went from looking at the 2017 recommendations to then in 2019, I was asked to write a paper looking at the international community and say, what lessons can we learn from across the globe? And what what can we bring home? And lots of great ideas happening. I mean, the globe looks to the United States, but it's really important that we also look around the world. And so one of the things this paper talks about is looking at big data, how systems are looking at data to drive change, even looking at how systems had responded to prior disasters for sustained improvement. And then finally, some really cool work in the UK and other places in terms of looking at mental health as public health. And this was all pre-pandemic. And it's interesting to look at that paper now and think about what it means in the post-COVID era. Next slide. Again, learning from disasters and sustaining improvement. One of the things that we have the opportunity to do with COVID-19 is to take mental health reform and support it through planning and long-term sustainability as we are in this pandemic looking ahead. And teletechnology is one of the ways that people are thinking about that, so that the mental health system could be considered strengthened as a whole beyond this crisis. And this is from the World Health Organization, a paper they put out called Building Back Better, looking at case examples from around the globe that I think are really enlightening in terms of thinking about mental health services moving forward. Next slide. Again, mental health is public health. We have our Suicide Prevention Commission now in Michigan, school efforts to look at mental health needs early. Again, looking at the UK, looking at Mental Health for All, UK Thrive into Work, really helping the workplace be a place of getting support and enrichment, and also access to services if people need to take time off, as Kevin pointed out, since mental health is one of the major drivers of workplace disability in the United States. Next slide. What about behavioral health and justice practice reforms? Next slide. Well, the sequential intercept model is something that we've brought to Michigan. We've had big statewide summits. It may be time to do one again. We have the Mental Health Diversion Council. We've really looked at intercepting the justice system by looking at what we're doing at the community crisis service level, law enforcement, courts. You heard about this from Kevin. It all aligns. The sequential intercept model is a national framework that was codified into federal legislation in the 21st Century Cures Act as a way of identifying individuals with mental health and substance use challenges and redirecting them into treatment, which is a better approach than silting them into the criminal legal or the juvenile legal system. Next slide. We've got a lot of experience now examining police-based practices, so it's only based on those experiences as well as the current need to address what's happening and think about a smart way to model when does a crisis response require police and when does it not require police. And there's a lot of dialogue about this. There was recently a joint statement put out in Michigan looking at these issues around behavioral responses, as well as law enforcement responses and emergency medical personnel as a trifecta of responders, and knowing who to call when and then how they work together when they're all needed at the scene. Next slide. We've done a lot of work in Michigan, actually driving the country. Again, I got to thank Linda Zeller for allowing us to do this. We did a multi-state peer learning collaborative in 2017, looking at individuals found incompetent to stand trial. Oops, if you can go back to the other slide. Oh, back, one more. Thanks. And that drove SAMHSA actually to help develop, with Policy Research Associates, a diversion strategy for individuals found incompetent to stand trial to maximize jail diversion. And we've been talking with some of the legislators around re-examining the need, for example, for competency evaluations for misdemeanors. Many states are eliminating misdemeanors from the competency system so that instead of getting routed to a state hospital, they get routed to the civil system or maybe even an outpatient restoration program. So there's more to be said about that. Next slide. Linda Zeller and our own Jackie Prokop here in the state's Medicaid office wrote this fantastic paper through the Square One project, looking at health reform as justice reform and really understanding the role of Medicaid, care coordination, and community supervision as another way to ensure that people involved in the criminal legal system are getting access to care so that they don't get routed back into the criminal system. Next slide. And I see in the text, all of this relates to the link between race and involvement, absolutely. And I think I have more to say about that as we go forward. National trends in behavioral health crisis response is another place where we're seeing a lot of movement. Next slide. We see the current problematic system where our options are to call 911 and you get a law enforcement response pretty predictably to a behavioral health crisis, and not many options beyond that. And that's not what we want to see in the future. Next slide. So before COVID-19, SAMHSA released the National Guidelines for Behavioral Health Crisis Care, a practice toolkit. Next slide. That really drives a more friendly system where you have multiple options, a crisis hub, a medical response when needed, 988, the emergency number, and again, a law enforcement response when necessary so that nobody's in an unsafe situation, but a minimized law enforcement response as much as possible so people in behavioral health crisis can access an array of community services across a vital continuum of care, which includes psychiatric hospitalization if needed, but might include other types of services that to date still are being built out, including crisis stabilization units, bridge clinics, and other opportunities for crisis residential and crisis respite. Next slide. And these are the kinds of things that the behavioral health crisis care calls for, which includes not just responding to a crisis, but building in warm lines and crisis call lines for people to talk to before a crisis arrives, and then allowing for opportunities for response and stabilization that's accepting of all referrals and not picking and choosing who can call, but really being available to all the people across Michigan. And this is, again, a national framework. Next slide. During the COVID pandemic this summer, the FCC designated 988 as the national number for National Suicide Prevention Lifeline to make it easier for people in suicide crisis to call. And it is anticipated that this 988 number will become the uniform number as an alternative to 911 for people both needing to talk, needing referrals, and in a suicide crisis. Now, there's a lot of work to be done to figure out how that all maps together with the work that's happening within each state, but there is movement in that direction. Next slide. And to that end, SAMHSA just released this new compendium. I will admit that I am a lead author in a couple of the papers here, again, through the National Association of State Mental Health Program Directors. Crisis Services, Meeting Needs, Saving Lives. You can get it online, free and accessible. And the idea is that SAMHSA had was putting together the series of papers that the National Association of State Mental Health Program Directors released along with the Crisis Toolkit to make a usable compendium so states and local regional entities could figure out how do they fit into this crisis response. And I would say Michigan's doing an excellent job, and we'll talk a little bit about that. Next slide. Also, new models of clinical service delivery. Next slide. We have excellence in mental health through the Certified Community Behavioral Health Clinic Demonstration, the CCBHC, which Michigan is now a participant in, which allows for some of those things that I talked about before: bridge medication, reach-in services, connectivity with justice agency, day of release access, quality measures to include reduction in jail admissions, and an easy on-ramp and easy accessibility to behavioral health care with proper funding to allow the infrastructure necessary for that access. Next slide. And again, Michigan and Kentucky are now participating in this CCBHC demonstration. So it's super exciting time to think about how this is all going to weave together. Next slide. Where there are problems, there are solutions, and that gives us a lot of hope. We can see for ourselves with COVID-19 how rapidly we shifted to telepractices and other types of responses. Look at us now on Zoom. It's amazing how adaptable we've been. Next slide. So the proposed service array will include an effective strategy for suicide prevention, approaches that better align care to unique needs of the individual across diverse populations so that we no longer have inequities. Preferred strategies for people both with mental health and substance use crisis being combined, a key element to reduce the psychiatric hospital overuse, but still have it available when it's needed, eliminating psychiatric boarding in emergency departments, and eliminating the drains on law enforcement for more appropriate and less fragmented access to mental health care. Next slide. And so Michigan is really able to look ahead with the national landscape. We've got a lot going on. These are just a few exciting things that are happening. MyCal, as Michigan's sort of early version of 988 and an augmented crisis service array that's being built out. I see Krista Hauserman is present and listening. She's been our lead on this MyCal activity from the state perspective. We've got our CCBHC activities underway. We've got certainly expansion of telepractices, and we're looking to see where the federal government aligns with that. We've got jail and pre-trial, if you could go back. Thanks. Jail and pretrial task force work that happened before COVID-19, but made several recommendations through the legislature. The Mental Health Diversion Council is working closely with the Michigan Commission on Law Enforcement Education and Standards to help develop law enforcement training and other diversion strategies. Opioid Crisis Task Force continues, the Suicide Prevention Commission, the intentional work on diversity, equity, and inclusion, and examining all of our data from a race and equity perspective, and our work with child psychiatry consultation and other activities to help promote the needs of the young, including supporting pregnant moms who have substance use and mental health challenges so that we can get that intergenerational prevention strategy in place early on. Next slide. So in 2018, another paper we worked on was establishing these bold goals, really thinking about what are we doing in medical care to reduce cancer and reduce HIV impacts? Why can't we do the same thing to improve mental health outcomes for people? And so we put out these bold goals: better access to screening, identification, and timely responses, more access to effective medication and evidence-based therapies, more compliance with legal requirements for healthcare networks and network adequacy, access without delay to the most appropriate 24/7 psychiatric needs, diversion from arrest, detention, and incarceration, 100% reduction in homelessness for people with serious mental illness who could be permanently housed, and 100% of suicides prevented. Now, we know that these are bold goals, but if we don't establish bold goals and have a vision of where we're trying to get to, we won't get there. And so it's really important to set those goals now. Next slide. It's an exciting time. There is a new message. We really need to think about this continuum. The partnership between the three branches of government is critical in establishing this continuum. Getting people into self-care, thinking about Malkaya's inspiring story about how she's learned to manage her own illness with support and help, but while she's also supporting and helping others, including her own family, including working with her faith-based organization and her own work and employment with reducing stigma, Kevin's work with NAMI, looking at family outreach and engagement, and then looking at all this array of services that we can build out before we get into the need for a state hospital bed. Of course, some people will still need those services, and it is a safety net that we can't ignore. But we really want to think expansively at an exciting time. Even in this time of crisis with COVID-19, we can build back better. Next slide. So the hardships of COVID-19, it is hard. And I don't want to be a Pollyanna. There's a lot of work ahead, but they've only highlighted the importance of that work. And a forum today allows us to put the punctuation mark on the need for partnerships, which are paramount in getting to solutions together. And with that, I think I'll conclude and allow opportunity for dialogue and discussion.
Dr. Pinels, thank you for that super thorough presentation. As you all can tell, this could have been a topic of its own. There is so much to cover here. A question did come up relatively early in your presentation, Dr. Pinels, and it was specific to synthetic drugs. And the question is basically, aren't they less expensive? And as a result, wouldn't there be a role for them during a situation like a pandemic?
Yeah, I mean, I think it's an interesting conversation. I think if you're talking about where the opioid crisis fits in, what we are really trying to do is figure out how to get, we know that there are certain substances, alcohol, opioids, and tobacco that have medication-based treatments that are critical for prolonging life and improving quality of life. And one of our goals has continually been to make sure that people have as much access as possible to those medications. And so if that is what is meant by synthetic, I'm not exactly sure, but it's really an important strategy to ensure that there's medications and that there's access to medication, what we call medication assisted treatment, or MAT, sometimes people call it, for those substances of the substance use disorders that have medications attached to them.
I'm pretty sure that the person that asked the question that was not what they intended. So we'll cover that one offline. We will get an answer for you once we clarify your, if you could perhaps send a clarifying question, and we will cover that after the session. And then Dr. Pinels, there was also the question that I know you saw as it popped up, and that was specific to what Michigan is doing to identify and address racial ethnic disparities in access to behavioral health care and correctional facilities. Did you want to elaborate on that?
Yeah, I mean, I think, again, we were fortunate to have the Lieutenant Governor running the Jails and Pretrial Task Force with the Chief Justice, which came out with a number of recommendations. Also, with the COVID-19 pandemic, the Lieutenant Governor established a committee on diversity, equity, and inclusion to really look at issues related to the COVID-19 pandemic. With regard to behavioral health, this is a topic that the Mental Health Diversion Council is also starting to explore. And the data that we've collected through the Center for Behavioral Health and Justice is something that we're looking at, how we can better understand what the racial and ethnic challenges are for people that are caught between multiple systems where those disparities really do end up playing out. We certainly know, for example, that because of the disparities in behavioral health care and the disparities in terms of how criminal legal system is meted out, that we have a bigger problem for people that have that intersectionality. So there's an intentional discussion about looking at that data as we go forward with solutions.
Thank you for that response. So Linda, I'm going to turn it back to you now to lead the panel discussion among, if our panelists can return to their cameras on, that would be great. And I will back out here. Thank you.
Thank you all. Hopefully our attendees from House and Senate and administration agree that we have three really unusual experts that you heard from today, and hopefully they can be great resources to you and your staff as you consider working on these important areas. I want to first, for my first question, and anyone can answer, but I for sure want to hear from Dr. Pinels. We've focused a lot in this panel on the global system, and the kids system has to be much different, right? Because it's complex. We heard from Kevin about the suicide rates and the challenges related to that. We heard from Malkaya, the experience with her daughter and grandchild, and from Dr. Pinels around some of the juvenile justice issues. My question is, specifically for Dr. Pinels, you have led nationally and in our state mapping out a model for care for adults, a SIM model, right? What do we do in treatment to prevent people from ending in the in the justice system? Is it time to model that out for kids? It's my understanding that more than 50%, some people say as high as 80% of the kids in juvenile justice were child welfare kids prior. And a very high percentage of those child welfare kids have an adult in their life, in particular, dealing with a substance use disorder. And it just feels like it's time for that. And I wonder, and the whole looking at suicide and suicide prevention, it just feels like we need to back way up in our system, way before treatment, in order to do a similar model for kids. So Dr. Pinels, can you speak to that a little bit?
Yeah, I can tell you a couple things that have happened in Michigan. For example, in Washtenaw County, after they did the adult mapping exercise, they did bring in some consultants and do the system mapping for juveniles as well, which brings in other partners like schools and child welfare and all of that. And so there have been there are probably other examples of that, but that's one I'm familiar with. At the state level, we are having lots of dialogue within DHHS between the child welfare system, the juvenile justice system leaders, through our CSA, as well as behavioral health and developmental disabilities and Medicaid. In fact, we have regular calls now where we review cases systemically with the leadership to try and understand where are the barriers to care. There is a lot of work also going on right now within the child welfare system around transformation, unfortunately, in part related to a tragedy that occurred earlier in the year. But what's happening is multi-stakeholder involvement in looking at system reform and practice reform that I think has a lot of promise. And it will require the backing up to further those conversations about the relationship between mental health and child welfare. And finally, I would say that the governor supported funding for what we call MC3 for Moms, which is a program that will allow consultation to OBGYNs who are working with patients who are pregnant and have substance use and mental health challenges, so that they can work with them as the baby's being delivered and help support positive outcomes from a behavioral health perspective in a multi-generational way. And at the same time, our state opioid response money is targeting working on helping reduce the risks of neonatal abstinence syndrome and looking at these strategies for plans of safe care for families. And so I think there's a lot of opportunities to think about how those systems and how those interventions work together to improve outcomes across generations.
Thank you. And Kevin, can you clarify? It looks like we had some questions about suicide rates.
Yes. The national suicide rate, and I should correct what I just typed in the chat. Since 2001, the national suicide rate had increased by 30%. Michigan is slightly higher than that. Michigan came in around 33% suicide rate increase. So we've got a lot of work to do.
Linda,
Sorry, thank you very much. Yes, go ahead, Malkia.
I just wanted to add something to what Dr. Pinel said also. I've been doing a lot of work with Oakland University in Oakland County and Pontiac, Michigan, and Pontiac schools. And one of the things that we've been doing is talking more about trauma. I don't think that there's enough conversation around trauma. I think the different systems need to understand better, especially criminal justice system, the child welfare system, need to understand the effects of trauma when they're looking at behaviors. Unfortunately, in Oakland County, the Pontiac School District over 35 years has sent more children to Children's Village than any other school district in Oakland. And you can't say it's because of poverty, because Pontiac has not been poverty stricken for 30 years. But if you don't take into consideration the trauma factors, what's going on in the community, in the households, it's a real need to break down the silos. And I know that people have said this before, but we really do need to bring all the systems together when we're talking about system redesign. Because if the workers and I'm losing my train of thought, but the workers that are working with the families, if they feel that it's the families are defective and they don't take into consideration social determinants of health and trauma, then you're going to keep seeing the numbers that we're seeing. And I've been to Lansing. I've asked legislators, it can't be the zip codes. It can't be the parents in these zip codes out of a whole county that don't know how to parent. It's something else that's going on. But if you have an opportunity to see the film Resilience, that film will open up your eyes to trauma, the effects of trauma. It's dated. It came out about 5 years ago. But in the state, Washington State, they brought all of their systems leaders together after they understood the effects of trauma better and started investing the money in early interventions, the kind of things that Kevin was talking about today. And over the course of 5 years, they saved millions of dollars. A lot of times we want to spend more money, but if we targeted the money in places that were more effective, we wouldn't need new money. We just need to spend the money that we have more wisely. And oh, I'm sorry. Go ahead.
No, I didn't mean to cut you off. I thought you were done.
Oh, that's okay. I
Okay.
can get on the roll. I'm done.
No, that's great. So I'm going to shift gears back again, if I can, for a next question. So one of the things I think all the work all three of you has done has shown, and including the access study that the Health Endowment Fund invested in before I was there, has shown that policy making around this issue is extremely complex because of what is available in the public system, what is available in the private system, how what's available changes whether you are privately insured or insured through one of our state safety net type programs. We've seen some exciting work, bipartisan work, over the last 10 to 15 years, and most recently around crisis. Leaders from both parties and all three branches of government, as has been mentioned, have stepped forward with things like MyCal, federally, another bipartisan effort that we had one of our senators on, Stabenow, CCBHC, right? So there's tons of bipartisan agreement and tons of moving parts, both in Michigan and nationally, to try to make it so that it feels like one crisis system, no matter whether you're privately insured, publicly insured. And I'm wondering if you all are starting to see some movement towards systemic thinking between MyCal, the crisis line, and the crisis intervention teams, and CCBHC. Can we expect in this year or two to see things change so that it matters less what type of coverage you have or what type of system you started in, whether it's child welfare or juvenile justice? Might we see things start to level out through CCBHC and MyCal in particular? Kevin, you probably have a unique perspective as the first place families call. I don't know if you have thoughts on this, or Malkiah.
I do. And, here's what's interesting, Linda. My hope is that CCBHC is going to help us level the playing field, for lack of a better term. But I want to be cautious in that, because CCBHC is not the silver bullet. It's not 100% the answer. And especially to our legislative friends participating on the call, CCBHC is not the answer. It is a nice piece, it's a component, but it's not all. I also was thinking as you were speaking about the difference maybe in let's say, what's available via Medicaid or the public system versus private. You know, in many situations, we found that when we put in all of the factors, social determinants, all of the things that we look at that treat the whole person, we found more often than not that people have better or more access to resources via the public system than via going to people who have private insurance. And so it's an interesting kind of disparity.
Linda, it's time to wrap up. So thank you all. This has been an incredible panel of presenters. Thank you for your time today. There's one outstanding question that I think Kevin can probably answer quickly. If not, we will follow up following the session with the question. And that is specific to the Michigan's funding for mental health compared to other states. What are the trends around that? How do we?
I'm sorry, Kathy, really quickly, it's a broad question. I will follow up with Dr. Tanadar on that.
Very good. Thank you all so very much, our participants today, and our really excellent presenters. Arnold, I'll turn it back to you.
Thank you, Kathy. Thank you for putting together a fantastic panel. Thank you to all our presenters. I've written down your names for other sessions that IPSR might hold in the future, so you might be hearing from me again. And I again thank Kathy for pointing the way, and you all for the work that you do. Our thanks again to the Michigan Health Endowment Fund. And I'd be remiss if I didn't thank our IPSR communications and marketing staffer, Cindy Kyle. She noted in the chat early on where these sessions could be found. We'll be sending up a follow-up email as well. Thank you all, and I believe, Kathy, if it's appropriate, you tell me no, hop on. Our next health policy group session will be February 8th. Is that what we're looking at, Kathy?
That's what we're tentatively looking at in the afternoon, and it will be on pharmacy cost.
Okay. Again, thank you all very much, and look for updates along the way. Be well. Thank you.
Be well.